Are we talking about the two ends of the spectrum of a disease of lumbar canal stenosis? Like for example, this one, 64-year-old lady, retired teacher, significantly disabled because she can't stand more than 10 minutes. When she starts to walk, she can probably walk more than 5 to 8 minutes. Gross fascial arthropathy that you can see here. Lumbar canal stenosis, we will all agree. And when you do the flexion extension standard, significant instability, I can bet all of us here would say that we need to do a fusion here. Whether you do the open techniques, the T-lifts, whatever, we did a minimally invasive surgery here for this one. So no arguments here. Or this one, 79-year-old diabetic, chronic kidney disease with PTCA, severe stenosis, not the one who walks around too much, but disabled. We'll all agree with the flexion extension views looking not so bad. We probably do a decompression, whether you do the laminectomy or the over-the-top MIS, that's your choice. But we are here, me, Agni, Arvind, we'll try to send a message across to all of you all. We are looking at the gray zones. And that's what we are looking at. So a 74-year-old diabetic, retired army officer, chronic low back pain from the age of 30, where he was actually working in the services. Minimal back pain now, significant claudication and disability, a glass of whiskey, typical serviceman, occasional smoker, pulsations not too bad, right L5 deficit in the last 2 months, early prostatic surgery earlier, inability to control urine, but that was not prostatic, obviously it was neurogenic, and now realize that despite an epidural in the past 2 years ago, which lasted about 4 to 6 months, he's disabled. We, as usual, get the neurologist involved, got a neurodiagnostic study, EMG confirmed that it's more compressive rather than neuropathic, and that's his images. Now, when you look at this, inherently there is a degenerative grade 1 listhesis, isn't it? So the question arises, should we fuse or not? Then we look at the MRI, convinced severe stenosis at the same level, so corroborates the evidence of the L5 being deficit. And the axials, very significant. So there's no question asked that we have to operate. But it's this moment for all of us, the question arises, do we fuse or not? Now a non-fusion guy like me would stand up and bring out that article, classical New England Journal of Medicine, which says that decompression surgery without fusion gives you the same results. They went a step ahead and said, even if you have a degenerative grade 1 listhesis, actually it doesn't change the result, even if you decompress. And I remember one of the registrars in one of the corporates always said, "Arey sir, ye to medicine ka journal mein hai. Un log ko orthopedics kahan se malum?" You know, so these are the ones who will dispone and stand and say, no, you should fuse. In European Spine 2017 nearly said the same thing. So they kind of corroborated more evidence. But the one line I would like to highlight is, only 1 in 10 patients in this group ended up having a fusion at 36 months. So that means every 10th patient that you do needs a fusion done at 36 months. In a cultural society like India, would that actually be accepted? So literature is ambiguous. They said if you do isolated decompression, does not systematically result in postoperative destabilization. Or if it destabilizes, doesn't mean you have a poor outcome. And this was enough number of articles, but equal number of articles came between 16 to 18, which said the opposite. And this ambiguity is what we are talking about. Blumenthal gave the first possible meta-analysis in 2018, which he said, preoperative slippage more than 2 mm, disc height more than 6.5 mm, that means a preserved disc, and excessive facetal sagittal orientation with effusion. All 3 factors made a pure decompression surgery functionally bad in 75% of the cases. In 19, he added the concept of having sagittal balance to it. So let's look back at my case. If you look at the preoperative slippage, less than 2 mm in my case, so it stands, disc height less than 6.5 because it is a settled disc, and no excessive facetal sagittal orientation. Probably one of the reasons that we got away without knowing, without doing a decompression, and this is 9.5-year follow-up, excellent results in 9.5-year follow-up. Let's fast forward to now, 2023. And in spine circles, this is the article which is running around now, which looks at 4 criteria to decide whether we need to fuse or not fuse. One is segmental instability, which means if you have anything which is less than 3 mm translation, probably don't need to. More than 5 mm, probably we need to. Combine it with what are you going to decompress? Are you doing a central canal stenosis or are you doing a lateral recess of foraminal? That matters. The sagittal balance, which is something all of us don't look, even for that matter, not too many spine surgeons look into, matters. But clinical, whether the patient has more leg or back, matters. So in a pre-existing listhesis, like my case, there was already a grade 1 listhesis, but is it a criteria to fix always? No. Why? Because when the discal height drops, it's actually stabilizing, which means you have a facet which is acting like a fulcrum, and on which when you stabilize, it is bound to slip forward. Are you all here with me? Which means if your facet is the fulcrum and the disc is settling, it is bound to be a listhesis, isn't it? So actually listhesis could be a restabilization process. So all listhesis is not unstable. This is what Krishna said in 2018, and mind you, the ones all of us who have read the Kirkcaldy-Willis said this in 1982. So we go a long way back in what we define as the instability criteria for listhesis. The one thing which matters is how is your decompression going to unfold? The one on the left actually is a central compression where we are going to probably easily manage to do the root decompression. If you look at the canal size in both, they are nearly similar. But in doing the one for the right side, you're probably going to excise the more of facets. Here you're probably going to break down a lot of stable listhesis that's been maintained. And therefore, depending upon whether you're going to do a central, a lateral recess or a foraminal, your approach changes. This probably is one of the important criteria to decide. The last point about sagittal balance, it's coming up in a big way, probably the future, or is it a hype? We still don't know. But segmental kyphosis, we all know lumbar spines are inherently lordotic spine. But segmental kyphosis should probably make your ears stand up. And therefore, in the future, what might matter will be the criteria of the SVA, the pelvic tilt, the pelvic incidence, and the amount of focal disangulations. All this might be a criteria to decide whether to fuse or not. But what surpasses all of them is clinical. Is the patient having significant back pain in activities of daily living? Because all these patients are old. They're not going to climb up the Himalayas. They're not going to run marathons. Some of them might. But if the back pain in what we call as activities of daily living is not too bad, consider staying non-fusion. If the leg symptoms are far more than the back, probably start looking at a non-fusion technique. If the need for pain medications in back pain is significant, you could probably start looking at fusion. And the disability matters. If all the 4 criteria clinically are pointing towards a non-fusion, stay by it. The fear normally is that if you don't fuse, somebody else will. That shouldn't be a criteria to fuse a spine. And that's why preoperative counseling, preoperative discussion with the patient, and let the patient be a part of the decision making, which I think is very important. What are the relative determinants here? Age. Now, age is a very broad spectrum. You could have a chronological age which doesn't match with the functional age. You look at the functional age which matters, comorbidities, practice setting. Where are you going to be doing this? Is this going to be a corporate hospital in Mumbai or in a rural hospital or a rural camp in Gadchiroli in the central of India? Culture. In the West, you could say that I'm going to do just the L4-5 and the L3-4 and the L5-S1 are bad, but we'll look at it later. They might accept it because most times they don't need to spend money from the pocket. The state looks after it. But here, if I say I'll do an L4-5 today and I'll do the L3-S1 next time, half of them may not turn up. Ek baar karna hai, jo karna hai, is baar karo. That's the attitude that we have, right? And socioeconomics. And here I'll use the word, what old Shushrut, the father of ancient surgery, Indian surgery, told his disciple, Dviga, and he writes in his biography in 600 BC that a tenets of a great intervention is punar utpadaniyata, which means reproducibility, upalabdhata, which means accessibility, kshamata, the capability of the surgeon, and benefits, labha, to the patients. On that note, in a stable listhesis with stenosis, a technically well done surgery which doesn't hamper the pars, doesn't hamper the facets, doesn't denude the facets, are very important rather than trying to cover up the fallacies of your surgery by putting in implants. A release without fusion is enough in patients where radiologically no hypermobility, whether anteroposterior or angular, very good settled discs. You don't need to jack up. Settling itself is a natural process of stabilization and doesn't need excessive facetal resection. Global and segmental sagittal alignment might be the criteria in the future, and all of this, however, has to be considered in light of the patient's functional age, clinical presentation, comorbidities, and the practice setting and the socioeconomics. Sometimes doing less is more. Thank you.